to your treatment. So to conclude, what I've shown you a few patients which demonstrated a very unique opportunity to study simultaneously several imaging techniques. I think it's one of the best tools to correlate the topographic information with the tomographic information, with the vascular information of the retina, and to follow up on these patients, to monitor the progress of the disease. Now, we don't have to actually keep on doing repeated invasive procedure like ICGs and fluorescent angiogram. And this has certainly, personal level, it has helped me to understand the macular pathology which we didn't understand till some years ago. Thank you so much for your patient hearing.
For telling us the role of autofluorescence in multimodal imaging. Now Dr. Raman is going to talk about some of the investigations which we still have to use even in the retina. So what is the role of these modalities he's going to cover over the next 12 minutes.
Thank you, Dr. Vishali, for making me part of this course. Very good morning to everybody. As I move along in this course, in this talk, I'll be showing you the definite and irrepressible role of USG in diagnosing the posterior segment disorders. While MRI and PET directly, they can just we can visualize some of these intraocular tumors, but their definite and the better role is in diagnosing the systemic associations of these tumors. So as we all know that I don't think there's still now a substitute there to USG in diagnosing the posterior segment in case of opaque media, be it non-traumatic cases, be it trauma, be it uveitis. And in intraocular tumors, it provides the diagnosis to us most of the situations. In few cases, we need CT, MRI, or PET to confirm it, but most of the time it comes out with the diagnosis. Whenever you're seeing a USG, you are seeing for things like vitreous, retinochoroid, and disc. And once you are looking at the vitreous, and there are some point-like or dot-like echoes which will give you a clue that whatever you're seeing in the vitreous is normal or not. And depending on the A scan and B scan, you will pick up the vitritis, endophthalmitis, and vitreous hemorrhage. It is very important here to keep the clinical picture always in mind, because if you don't know the clinical picture, you will not make a good diagnosis. Because if you have a hypopyon in front of the eye and you keep making a diagnosis of vitreous hemorrhage behind, you are making a big mistake. So you always think of, horses outside when you hear the clatter of hoofs, not zebras here. And once a patient presents with a post-cataract surgery inflammation, look for the things like a nucleus there, or a nucleus fragment drops, or even IOL, and it can be picked up with USG only. And the most important role of USG, once you see vitreous membrane attached to the disc, you look for is it a retina is on or is it off. So there are definite clues on the ACE amplitude scan and the brightness scan to tell you you are dealing with RD or with PVD. Apart from that, the diabetes, where we are dealing with these patients, the VR surgeons have a tough time in knowing what's behind this vitreous hemorrhage. No other tool apart from the USG will give you this sort of information. What are you dealing with? Is it a tabletop RD there? Is it going to be repairable, or am I able to finish this surgery? So no other tool can give you this kind of a picture there. And as we move on with the newer high resolution probes, you can pick up information like CMEs and optic disc cupping also for the prognostication of these patients. And trauma, as I've already said, is a nightmare for any VR clinic, because all the things are now mixed up here. You have hemorrhage mixed up with RD, with choroidal detachments. So picking a choroidal detachment, hemorrhagic or serious, can be done by USG, and not only diagnosis, but it will give you a clue when to operate in these patients. Because once they start lysing, only then you take up these hemorrhagic choroidal cases. Cases like posterior perforation cannot be picked by any etiology, but by the USG only. And then retained intraocular foreign bodies, using a non-radiation, non-invasive procedure, USG, you can diagnose and even localize these magnetic and non-magnetic foreign bodies like cilias, glass, iron, whatever you want to see. So in this study from our center recently published, we saw that the trauma is the most unreliable factor in USG. If you have a reliability criteria of pre-operatively analyzing your USG finding, the trauma is the one where are you most likely to miss there, but the sensitivity is something like 90%. And if you take further in this unpublished data, we have seen that in trauma is not the foreign body. Foreign body can be localized very easily with good sensitivity. It's the posterior perforation which is most likely to miss. Okay, so we showed here that the USG is to be taken very meticulously in cases of trauma, and the findings that we may miss some of our USG on USG are more in cases of trauma. Uveitis, because of the inflammation there, we are not able to see the media clearly. So you need USG in the situations where media is grade 4 to 5, and things like the choroidal thickening, exudative bodies can be picked by none other tool than USG only. And literature has enough evidence now that infective etiologies, they have some kind of a pictures there. There is a very high sensitivity of picking a toxoplasmosis. If you see a lesion which is on the temporal to the disc and associated with focal thickening, it has to be a toxoplasmosis. If you see a peripheral granulomas radiating with radiating membranes, it has to be a toxocariasis. And nobody can miss a finding of a cystosarcosis which can be picked on, you don't need these PET and MRIs for these. And of course the granulomas due to any infective etiologies can be picked by USG. Till date, in opaque media, to diagnose a VKH syndrome, you have to find whether the patient has retinochoroidal thickening or not. So it is their tool to pick retinochoroidal thickening. And to manage these patients, whether they are responding to steroids or immunosuppression or not, if you show or document the decrease in retinochoroidal thickening in the peripapillary areas, this can be done by USG. The advances, the people say that EDI is better, but we cannot do the extended depth imaging OCT in case of opaque media. So what we have done a work here in PGI, like we have used high resolution probe and using immersion scans instead of on the lid. We have found that the reliability of EDI and immersion USG is similar in case of USG. We can achieve same levels. And these pictures of T signs and these pictures of which are the sign of posterior scleritis cannot be missed on USG in opaque media. As I've already said, most of the times USG can make a diagnosis of intraocular tumors because the pictures are so classical in case of melanomas, in case of METs, in case of hemangiomas. Sometimes in case of atypical, where you need these entities like CT or MRIs. In these cases, the classical mushroom shape, the melanoma will not only, the USG will not only help making the diagnosis, it will also help to, how to manage these patients, how to move along, because there are classifications which have shown that if it is less than 10 millimeter height and all that, you can, it will vary your treatment. And of course, this entity, the entity of leukocoria, all the DDs of the leukocorias can only be unraveled with USG only. So the reality is, this is a beautiful line by Dr. Gass, it is highly dependent on somebody, the ultrasonographer. He has to be very skilled, his technique has to be perfect, and his interpretation and dedication is very important in case of USG. So it is very subjective and it has to be, mastered there. So as we move along to MRIs and PETs, as I've already said, they do have role in intraocular tumors, but the real role is in, a better role is in finding out the systemic the associations there. So in case of all the intraocular, the lymphoma, the PIOL, it is mandatory to subject them to, CSF and MRI to pick up the brain involvement early. So it is a test where you are suspecting PIOL. Like in this lady, we had a lesion. The vitrectomy was done, we found NHL, and she was positive for the brain lesions there. As I've already said, intraocular tumors, it can confirm the findings of USG, but it is not better than the PET scan. And I'll spend some time on the PET scan because, as you know, the CT and MRI are kind of anatomical imaging, and the differentiation is with the PET is the functional imaging. Here we are, seeing the FDG, the fluorodeoxyglucose, which is competing with glucose, which is taken by normal cells. But since the glucose is metabolized, the FDG is accumulated in the cells. The abnormal cells accumulate them, and then camera picks them up. So that's how PET uses, this fundamental of increased FDG uptake by abnormal cells. So it is being used in case of masquerade syndrome, and it is more sensitive than MRI and CTs. In this young lady who was systemically asymptomatic, presented with this yellowish lesion with exudative RD, and the clinical, the angio and the USG were favoring metastasis, and even her HRCT picked up a malignant lesion in the right lung. But there is no other entity which can replace PET, which will provide this information that this malignant lesion in the right lung is not limited to the lung, it has metastasized. All these hot areas are basically metastasis. The good thing with pool, or the best thing, is you can find out the primary there if there is an unknown primary. So if there is a formula there, like the amount of FDG uptake by organ, if it's more, that's probably the primary is there. And apart from masquerade, I said, the new rules which are of PET are coming up, which are pertaining to eye. People have shown that in case of lymphoma, if you are not suspecting only brain involvement, you can pick in a whole body PET scan the unusual sites, of the lymphomas, and a site where a biopsy is possible can be picked on lymphomas. So is its role in sarcoidosis. Recent papers have shown that in any case of unexplained chronic uveitis, if you subject these patients to FDG, this is a Western literature which shows that chances of picking the granulomatous uveitis, the sarcoidosis, and tuberculosis are more, because you are able to pick lymph nodes which you can subject to tissue biopsy, and you can pick up the lesions which are unknown till now. Same with the tuberculosis. People have shown that in case of tuberculosis, in the studies are available in endemic and non-endemic areas, that you can diagnose the cases of tuberculosis, and you can pick up the lesions in the body which can be subjected to tissue biopsy, and you can make a confirmative diagnosis of the active tuberculosis there. And of course, you can also monitor your treatment on PET scan. Here is this example of a young lady which tells us that you should not blindly follow these MRI and PETs, and once you are finding on PET, you should always do a tissue diagnosis before jumping onto a conclusion there. So this young girl presented with this mass lesion without any inflammation in the eye, 20/60 vision, and the clinical and angiographic and medicine favored metastasis, so we subjected her to PETs, and rest of the investigation was normal. The tuberculosis was less than 10. The PET was it showed that the increased uptake in the ovaries, and there is metastasis to liver, to peritoneum, all over, and the primary in the ovary. And we brought this news to the lady, and because her tumor markers were also high, the CA and LDH were high. But before anything, the tissue biopsy is mandatory in these patients, because this was not the age, and this was not the picture for the ovary there. So peritoneal the tissue fluid was taken, and it showed beautifully the multiplex PCR was positive for two genome. This is MPB64 and IS61V0, and subsequently this lady was treated with the anti-tubercular treatment, and she did well. And as you can see that down picture, that this is pre-ATT and post-ATT, there is a decrease in uptake on the PET scan, and this is how we can look for the resolution of the disease. So to conclude my talk here, I would say the USG is still it's an irreversible tool. I don't see any tool at the present time which can replace the findings of USG. So it's going to stay there. Just that the probes and the resolutions are increasing. People have moved on to the 20 MHz, and but there are certain problems with the high resolution probes. And MRI, as per the diagnosis of the intraocular tumors, it's okay, but it has a limited role for posterior segment disorders. But as for PET, this is an essential investigation for us, because these masquerading patients, sometimes we are the first physicians to have a look at them. So we should know and get them undergo a PET scan. Thank you so much for your patient hearing.
Thank you very much, Raman. The next two topics I'm going to cover, I shall be speaking on the role of wide-angle imaging and what advantages it has over the conventional image. We all know that we were used to of seeing 30 degree. We wanted to see more of the fundus. So we moved on to 50 degree. We wanted to see still more. So we started asking the patient to look down here and there, and we started preparing montages. And the best we could see with all the montages was 75 degree. This is the 7 standard fields which we all have been doing with expertise, and this here is the amount of the retina which we would still miss, which we always wanted to look at. So now with the advent of ultra-wide field angiographic camera, which is from Optos, we have an option of moving from 75 to 200 degrees. Now, is it just one of the fancy gadgets to have, or is it really useful to us? Let's see. This is the autofluorescence. You have, of course, seen beautiful autofluorescence imaging by Professor Gupta. This is just an addition to that you can actually scan the entire 200 degrees of the fundus in the real time. Or you can have the color images. You see a lot of green when you are doing color imaging with Optos, because it's not a true camera. It gives you pseudo color. I'm sure it will improve with time, but you can actually see the pathology in the real time. And for fluorescein, it's absolutely brilliant because you get a good quality of the entire fundus. So these are some of the things which you can do. Now let's see whether moving from 50 degree to 200 degree, does it help a retina practitioner in a clinical practice? I was trained very well by Professor Amod Gupta, but still I'm not as good as my teachers in looking at the periphery, because I was really not into putting the sponge or marking the breaks or making the drawings. So I was never very good at that. So for people like me, or the people who are, I'm sure, junior to me, who have not received that kind of training, this is a very good boon for picking up the detachments, breaks, myopic degenerations. Very important for documenting, teaching, patient education, because many a times, patient will not know what we are talking about. Now we have the patient education and, of course, the medico-legal aspects. Now this is an example here. You see there is a break. So I can just tell my fellow, go and laser, and he does the laser, and I mean, sitting in my clinic, I can document. I can tell the patient that there is a break here which we are going to laser, and this is what we have done to you. And if there are any other areas, you can document. Or a patient walks into emergency room with a situation like this, GRT, but his fovea is attached. You keep on telling the prognosis and all, he doesn't understand, but the moment you show him this, he knows what you are talking about. Are some of the lesions like chirpy and all, which can be documented, including the choroidal nevus. Sometimes a diabetic patient like this, the posterior pole, this is a 50 degree of course, which shows that there is a bad detachment. It has a tractional element, but when you see the periphery, besides this traction, there is a huge break sitting there, which can be documented. Or the monitoring after the post-PPV. Taking the images through the gas-filled eye was never so easy, and how much of the gas is left. And the persons usually tell you, I'm seeing small bubbles, I'm seeing fish eggs. And you will say, okay, I have put the gas in the eye. But the moment you show him picture, he knows what's going on and he feels happy about it. Or Sometimes this is a picture of a patient, and my colleague actually had a problem due to this because he was called in the emergency for a patient which he operated about 3 weeks ago. And the patient said he had a post-op follow-up 1 week before this picture. He was not seen by an attendee, he was seen by a fellow who missed retinal detachment. So the patient was upset and angry that his case of redetachment has been neglected. Fortunately, the fellow had done a picture 1 week ago, which showed the retina was attached at that time, but when he came 1 week later, his retina was detached. So it was not a case of a neglect or anything, it was just the retinal detachment developed after 1 week. So it's a great tool to document from the medical legal aspect as well. We actually in PGI cannot help without talking about uveitis. So it has a very great role in the intraocular inflammations. For example, this is a patient who was being managed by one of my colleagues, and the patient is after infliximab infusion. He happened to be in my clinic, and I had to decide whether he needs to receive another infliximab infusion or not. His vision was very good and he looked quiet to me. So this is the standard 50-degree photo. It showed the fluorescence, which was fantastic. So no active disease. Probably next infusion can wait and patient can be on Celsip or so. Till the time you look at the 200-degree and you realize all is not well. This central frame is 50-degree and you see there is something going on here. So you do the angiogram, and these areas here in the oval, they show there is something there, and sure enough, it has active vasculitis in the periphery. So if it's a Behçet's, and all of us who are dealing with these entities, we know that you don't quit treatment at this stage, because if I had not given him infliximab, he would come after few weeks or even sometimes within few days with a recurrence and sometimes with hypopyon. This is a patient again of presumed intraocular TB with the healed lesion. Again shows some healed granulomatous lesions, but by and large it was quiet. Fluorescence looks beautiful on the 50-degree field until you go to 200-degree. You realize how TB can cause occlusive vasculitis. And in the patient which has uveitis, which has some degrees of synecdoche attached to it, looking at the periphery is not very easy. And sometimes all of us miss these areas of capillary non-perfusion. That is why a patient comes with a bleed and then we end up calling it Eales disease. But if we are able to pick up our patients at this stage and do the laser, probably many of these eyes, we would be able to prevent them from going into a phase of recurrent vitreous hemorrhage. Diabetes, of course, is the mainstay. We are the world capital of diabetes, so we have to see the applicability of Optos in diabetic retinopathy. In diabetic retinopathy per se, it has led to change in the management strategies. For example, we always said diabetes is a disease of the posterior pole, and that was because we were not actually studying the periphery of the disease. So this is what we were always studying. This is what we can see now. Optos ultrawide, I have no financial interest in Optos, by the way, just the ultrawide imaging of this patient, which we saw here, which looked fine. You look at it, it shows probably everything is fine. These are some of the artifacts, mind you, which you get very commonly in the color image. But when you look at the fluorescein, it reveals that there is significantly more disease burdens, and there are large areas of peripheral ischemia or the non-perfusion, and of course more areas of retinal neovascularization which you can identify. So this is the right eye. Again, you see something is happening here in the far periphery, whereas the area which we always believed to be the metabolically active area where the burnt of the diabetes was, looks fine. And when you do the fluorescein, you see the entire disease process is actually in the periphery, and you are getting macular edema, which we now assume that is because of this disease burden in the periphery, which is producing VEGF and contributing towards the development of macular edema. So doing the focal lasers to this area is probably not going to help unless you treat or you manage the periphery as well. So this ultra-wide field fluorescein angiography has helped us in assessing the amount of the non-perfusion or ischemia, because it has been correlated that higher the glycosylated hemoglobin, which means poor the control, the more is the non-ischemia in the periphery. Probably that is why we used to say that the patients who have high glycosylated hemoglobin would have recalcitrant macular edema, because we were never treating the periphery for macular edema. The second change is that I am no longer doing, not I, but I mean most of the retina people have shifting over from PRP to TRPs. We are no longer burning the retina like hell, killing all the retina with PRP. We are moving more towards targeted photocoagulation to the areas where it is actually needed. We are doing more and more angiographic treatment to limit the peripheral loss in the patients. We are using a lot of navilas, but we are importing the Optos images to navilas so that you can actually see the areas in the periphery which needs to be targeted. This ultra-wide field images can demonstrate more than double the amount of the retinal pathology like non-perfusion and new vascularization when we compare it to our sacrosanct 7 standard fields by standard 7 diabetic fields. And it provides more information for deciding how to treat someone with clinically significant macular edema. For example, you can see here, this is a patient with recalcitrant macular edema, but there is a lot happening here which is responsible for causing this kind of recalcitrant macular edema. And this is a patient who is actually post-PRP. You can see it's quite a heavy PRP, but you still see there is edema persistent. Probably you don't need to kill the entire retina for PRP and you still have the edema. So even if you have done targeting, and we have our paper coming now comparing the TRP with the Pascal laser and showing that they are beneficial. And here is the already published report saying that since PRP can have significant morbidity, TRP is the solution. My time is running out, so I will just quickly run over the last case of angiomas, where you can see that 50 degree does not show, but you move on. And of course, you can scan, you can look at the new angiomas in the periphery, and you know what to do with them. Since my time is over, I will move on to my next talk, which is about OCT and what are the current advances we have in the OCT. You can put the next Dr. Dogra's talk on that, so we will save time. About OCT, we all know by now the time domain is out. No, this is not my talk. Please stay on my computer. We are now moving from spectral to adaptive optics. Now, spectral domain, we already know. Professor Amod Gupta has beautifully shown you all the images, the three-dimensional C-scans and the single-layer images. There has been a change in the nomenclature on OCT. We are no longer using the same terms which we were using in past, and in the recent workshop on the international nomenclature for OCT meeting, there was a consensus on the terminology, So what we see here is the posterior cortical vitreous. Behind that is pre-retinal space. Then this thing here which we are seeing between the fovea and the optic disc is nerve fiber layer. Then of course ganglion, inner plexiform, inner nuclear, outer nuclear, Henle cell layer. This is the outer nuclear layer. This beautiful line here is the external limiting membrane. This junction, which we used to call outer photoreceptor, is now changed to myeloid zone. ISOS line is being called ellipsoid zone. Then is the interdigitation, outer segments interdigitation zone, choroid and sclera. This is so that we are all on the same platform when we are talking about the terminology. We wanted to see deeper because Sir has shown you that RPE is responsible, and he has also shown you that choroid is responsible for causing atrophy in geographic atrophy in ARMD. But how do you see choroid? We wanted to go deeper. So we had enhanced depth imaging where we can see layers of the choroid. This layer here is the layer of choriocapillaries. Then we have large choroidal vessels, which is Sattler's layer, and then we have the small choroidal vessels, Sattler's layer, and then we have the large, which is Haller's layer. We wanted to see the vitreous and we wanted to see the choroid. So we had something called combined depth imaging, as you can see here, that you can go from the vitreous, retina and choroid by adjusting your optics on the Heidelberg. This is from the Heidelberg. So you can do combined depth imaging to see everything from vitreoretina phase to choroid. But still we had some shortcomings of spectral domain OCT. We needed a better resolution, we wanted to go deeper, and the problem with enhanced depth imaging when we do it with spectral domain is that we have to put the calipers manually. So we cannot really say what we are saying is true, what is the depth of the choroid, what is the volume, because it was all manually done. And we could not have three-dimensional maps from the choroid. So we moved on to the next technology, which is the swept source OCT. It's the ultra-high-speed swept source or the Fourier domain, which of course has good resolution, 5 micron, which can go deeper, and that is the basic advantage. Now, these here are the images of the spectral domain OCT, and these one are the swept source OCT. I would like to draw you, I don't do glaucoma, but it's great for glaucoma, my colleagues tell me. But you can see here the depth of the choroid, which you can see with, this is EDI, and this is the swept source. This is the article published in BJO, and these images are from that article, which indicate that with the swept source, the maximum you could go was up to 6 mm, and you had to manually put all that, not with the, this is with the spectral domain, not with the swept source anymore. You can go up to 12 millimeter and you have the algorithms and the machine doing it precisely where it should put. So, we can see vitreous. We are getting more and more familiar with the pre-retinal space, with the Clockett's canal, and we are even now knowing that sometimes you give an injection, it does not work, Avastin. You repeat it after 3 weeks, it works. And the theory for that is that if your needle or your drug has entered this space, it's going to work faster, but if you remain somewhere there, it may not work. Now coming to the deeper structure here, again you can see the layer of the choriocapillaries, the Sattler layer, Haller's layer, and this is the supracolloidal lamina. So you can see up to the sclera and these structures in detail. This is the C-scan overlay, and C-scan is the future because the world is moving from B-scan to the C-scans, back from tomography to topography. So this is, for example, the outer retinal tubulation in a patient, which you can see on the B-scan, go back to C-scan, put it on the fundus for getting exact point-to-point registration, as mentioned by Professor Gupta. Now let me show you just one quick image of age-related macular degeneration. We all know that anti-VEGF, they produce good short-term results. But we also know that those patients whom we have been injecting relentlessly for so many years, they are not preventing RPE atrophy, and you saw beautiful examples by Professor Gupta again. So now we are realizing that more than the RPE, it is the choroidal thickness which is decreased in patients with new vascular AMD, and it decreases further with anti-VEGF therapy. Now, whether it is the natural course or whether it is drug-induced, we still do not know. This is an example of a new vascular ARMD patient at presentation. You can see here the Sattler's layer you can't see. You can see some bit of choriocapillaries, and then you have the Haller's layer, the large choroidal vessels. You don't see Sattler's layer. And this is post multiple injections. You see the Sattler's layer is totally disappeared. It's just not visible. And even the Haller's layer is undergoing atrophy. So is something happening to the choroid with our multiple injections? We do not know, but surely we would have answers. Coming to the last aspect of the OCT, moving on to adaptive optics. What is adaptive optics? It's very simple. You add adaptive optics to OCT, it increases the lateral resolution, smaller speckle, improves sensitivity, so you can have 3D cellular resolution of the retina. What does it mean? It means that it gives you a resolution that you can see cones individually. It's very interesting, it's very fascinating. It's not a tool as yet for the busy clinical practice, but it's a fun tool to play with. Now, these are the images we have taken from the camera that we have very recently. So, you see all these bright spots. These are cones. Then you also see the spots which are not so bright. They are also cones. Because earlier they thought the brighter one was cone and not so bright was rod, but now they believe that the cones are perpendicular. So when you throw light, there is a Stiles-Crawford effect, because of which you will not see them uniformly. You will see some of them very bright, some of them not so bright. So right now we are at a stage where you cannot really see what is cone, but these are cones. This is the cone mosaic. It generally takes, when we do it, it generally takes, when it says 0, 0, it means you are right in the fovea centralis. And the camera that we have could take only 4-degree picture, and to take more than 4 degree, you had to ask the patient to move. When you come right in the center, sometimes the cones are so dense that you are not able to get the image because they are so compact that you cannot even get the image of the cone in the center. So it may appear like this, but these are all the spots. Then you can select the area of interest which you want to study. You can mark the cones and you can get the density color ratio, or you can see how far they are spaced from each other. I found it being more useful for studying the retinal vasculature actually, because when you are seeing, you can measure the thickness of the arterial wall, you can see the lumen, and I believe a lot of cardiologists especially in Paris, are using this to study the atherosclerosis and measuring the arterial AV ratio, because this is one tool where you can actually see and mark. This is the blood vessel. To focus on the blood vessel, you have to move your focus anteriorly. This thing here, which you see a shadow along the blood vessel, this is a normal. But this is the wall and this is the lumen. Of course, with the OCT angiography, now you don't have to inject the dye and you can study the blood vessels, but I'm not talking about that so far. Just to show you a couple of examples of what we all keep on doing in our clinical practice and how we keep on affecting the photoreceptors. Now you can see here a laser scar. You can see there is a scar beyond top, and you can see the cones in that area we have killed, absolutely killed. No cones at all. This is another example of a patient this is the pictures done earlier. Patient had CSC. Now he is resolved, but you can see this is matching the blood vessel along the leak. This one is here, this is the one. You can see this is a normal cone mosaic. You should be seeing cones like this. But you can see the point where it was leaking. There has been damage to the photoreceptors because of the fluid that has been persistent. Again, a myopic foveoschisis here looks good, but when you see here, there is a damage. So you have to be careful when evaluating some of these eyes. The left eye of the same myopic patient with macular hole, you see here the macular hole because there are no photoreceptors and just the underlying RPE. This is the heel scar of CNV. So, last patient I am going to show, this is the patient who had active retinitis in Behçet's disease. And this was not the time we did not have adaptive optics. He was responding to treatment, but when he came to us, you can see here he still has very fine perivasculitis. And when you focus on the blood vessel, this here is the nerve fiber layer. Since nerve fiber and blood vessels are within 50 micron of each other, you sometimes see both of them together. So this is the RNFL and this is the blood vessel which is showing the perivascular infiltration in a patient with Behçet's. I'm looking forward to, but when you focus it back, you see the photoreceptors are not affected in the region which is below the vasculitis because his vision is 6/6 and vasculitis has not affected. Very good for studying the optic nerve head. They have algorithms to measure the dark areas and the white areas, and you can do a lot in glaucoma. So to conclude, spectral domain OCT is of course very, very useful for studying the retinal pathologies, but not very good for going deeper into the choroid. Swept source is very useful for studying the choroid. C-scans are more and more the future because all the new technologies are now moving on to C-scans. And of course, adaptive optics is right now not very polished, the machine, because we don't even have the normative data for the cones. But I'm sure this is the future if you are wanting to study the photoreceptors. Thank you very much. Can you please open Dr. Dogra's talk? It has been loaded. It's not through laptop. Okay, so now we go on to the last talk of the session about the RET-CAM imaging of the retina. I would request Professor Gupta to join us for the panel discussion, and then we can take up the questions.
Thank you, Vishali, for the opportunity. I'm going to talk about one more modality of retinal imaging. This is also one of the probably first wide field retinal imaging which came into practice. Okay. And is not having a facility for RAD-CAM shuttle for fluorescein angiography, but is much more useful if you want to especially use as a telemedicine tool and you want to take it from a place to place. So basically, the applications of RETCAM include ROP screening and management, retinoblastoma cases, in juvenile glaucoma, shaken baby syndrome, and fundus fluorescein angiography, and also for certain anterior segment imaging, which I am not going to take up. So basically, the pediatric retinal disease is the most important, as I said already, is retinopathy of prematurity. I think this is moving of its own. I don't know what's happening. Retinopathy of prematurity, retinoblastoma, and shaken baby syndrome. In retinoblastoma, this has always been a gold standard because you can visualize most of these lesions before. I think this moves automatically. There is something here with my whole thing. And if you look at the data, most of the pediatric hospitals, especially in US and many of the developed countries, they'll have a RAT-CAM, and they would use it extensively, especially it will be in the OR and especially for retinoblastoma workup, and they'll keep on serially following everything on in these cases. And ROP, which has been of great interest to me, this images the entire retina in one shot. We at this time have a 130-degree lens, and since it is an instant documentation, so you can have a direct comparison of images, and it can be done by a technician or a nurse, or you don't need to be there yourself, and it's a very quick exam. Once you become expert in this, it will just take a couple of minutes, and of course it has been proven clinically as an entity which has helped. Not only the biggest has been the telemedicine based screening by the technician or by the nurses, and the interpretation of these ROP changes, since they require expertise, so it's not for the general ophthalmologist and a pediatrician that they would be able to identify these changes. So these wide field imaging systems, the way they have helped, that you can export these images to an expert anywhere, and who could immediately give the what is to be done for a particular patient. So ROP can be remotely evaluated from any place with this kind of a imaging system, and the exact accurate diagnosis is possible, and acquired images can be transmitted anywhere. Even if suppose if one expert has a doubt, it can go to other at the same time. And of course you can optimize the treatment, and these images can be permanently stored. Basically, you can have an exact documentation of a pre-plus and a plus disease, which is so important, because in today's time we know the identification of these two entities is very important. If there is anything pre-plus, you always follow all such patients, and plus, that means you're going to treat every time. And the plus disease, the way which we will look at if we document on the RETCAM, that if you have in two quadrant dilatation and tortuosity, then you label that as a plus disease. And you may see images like this with the same lens. Once you focus anteriorly, you may have tunica vasculosa lentis or the vessels seen. These are with the RETCAM pictures taken by me, and you can see these network of vessels. That means something very serious is going on behind. And you may have a hazy media like that, which might again predict that these are the major problems as far as the ROP is concerned. And the documentation exactly on, once you have taken these images, you can do on international, according to international classification, and that's how probably you know which cases to follow and where you would like to treat and what kind of treatment is required. One of the entity which probably we definitely need to know more in this country, we see almost 1/3 of the cases minimum, maybe 30 to 40% as APROP. This is because of the variable neonatal care we have, and so these flat vessels, they are seen, and once they are seen, we need to act very fast, because this is a very serious disease. It never leads to any stages, but straight to retinal detachment. I think I would like to just show some of these images which were given to me by Michael Shapiro from Chicago when he came to Varanasi long time back, and you can see he had taken these images with the RETCAM, and the date is mentioned here, 2002. Just after a week you can see the dilatation the plus disease has increased and the new vascularization is increasing. And a week after that, you can see again it has become further worse. That's just in about 2 days. So this has been treated with contour laser, and that is the way you would see these scars. They almost form like a diffuse, ultimately scarring, but everything has disappeared. And this was the other eye of the same child. You can see, despite good laser, there is a retinal detachment posterior to it. So this is what we'll see as a stage 4, and this would require a lens sparing vitrectomy. So I think it's a very good monitoring tool. It will exactly tell you what is happening. One of our cases here, you can see the plus disease so clearly, and if you go, when you see the entire image all the way, you can see there is almost a stage 3, and this case underwent laser photocoagulation, did the laser for this child, and you can see all the vessels have straightened up. So all those tortuous vessels have gone back, and everything, the disease has regressed. And this is another example, same. I think it's an excellent monitoring tool. You can see everything, that these vessels are straightened up, disease had gone back, the hemorrhage is not there, and same is here. You can see and monitor this. And this is a montage provided by Anand Vinekar. You can make exactly beautiful montages like this, and you can see all the scars going all the way up to the periphery. And even later, you may have cases where you have sequelae, like you have a macular drag, disc drag, or your macular heterotopia, so many things happening. What happens to these cases? And I mentioned to you about fundus fluorescein angiography. So you can have monitoring on a fundus fluorescein angiography as far as the changes in periphery are concerned. So these are the images provided to me by the Martinez. She's from Mexico. She does a lot of this work. And you can see these are mostly after Avastin injection. And what happens to the vessels after Avastin. And I think it has become one of the most important tools. If Avastin is being used, this has become a mandatory that you have to do angiography, as you'll see here. I think it comes down 2 weeks, you can see here, and what happens subsequently, that these vessels, they start remodeling. They might even leak. I'm not going into what happens to them, but you can monitor very closely all the changes, the abnormal shunts, the loops, as well as what is happening to these vessels. You can exactly see and keep on monitoring. But the problem is, you will even see them sometimes after 8 months, even they have been reported up to 24 months, the peripheral retina doesn't get vascularized in many of these cases. And you may have a leak like this, which might be seen, but although it is not leaking on the OCT, which you see down there, it's not showing any thickening, but you may have some of those things happening. You can also document sometimes these kind of pediatric retinal hemorrhages, which you might see. You might have, we have these cases, so many of them coming to us, the storage disorders, bilateral, you can see here, cherry red spot, and so many of these cases are sent to us by the pediatrician for imaging, like this is a congenital night blindness. I'm not going into all the situations here, so many cases of other problems during childhood. You have sometimes sepsis, you have vasculitis, and so many things happening. So I'm not going into all the images. So basically the advantages of a wide field RETCAM imaging is it gives you a very good documentation and the visualization. It's easy to use and it helps you in earlier detection, and it's a great educational tool. This is the only way you can teach. The problem is, if you don't have a very good dilatation, you may get poor quality images, especially in a very severe disease. So that is what a problem. At time it might overestimate ROP, or you may get those kind of dark spots, and the extreme peripheral retina may be at times difficult, especially if it is not that well dilated. So basically, RETCAM screening for ROP is really promising, and it is being used more as a telemedicine tool or as a teleophthalmology, and that it will have a great role in future once we have something cheaper coming in for this kind of a imaging. And of course it helps to identify the stage both of ROP and retinoblastoma, and exactly precisely what is planned for treatment for us to do in future. And as I said, follow-up and monitoring of all treated children, especially all these who receive anti-VEGF for ROP, is almost mandatory. You need to do angiography in these cases. So, as I already said, that since the FFA is possible with RADCAM3 and we can see many changes, I think this is a very, very promising tool as far as pediatric retinal imaging is concerned. Thank you very much.
Thank you very much, Dr. Dogra. Can we have the hall lights on? We would be happy to answer one or two quick questions before we hand over the hall to the next. So, yahan se. Yes. Thank you.
Just like as any retina scientist habit is that once you look at a optic disc cupping, the last thing you think about the glaucoma aspects. And I just when I was seeing that swept source image, the optic disc one on the right hand side. Any studies on optic nerve pits and using that swept source?
Yes, there are studies on optic nerve pits, on swept source. There are studies on foveoschisis in myopia. Because the swept source, you can get a better resolution of a myopic fundus, which was always a problem with the spectral domain. And there are studies showing a beautiful conduit between the optic nerve head and the retinoschisis that the optic pits can cause. They are all published. Yes. Our time is over. Thank you very much for coming so early in the morning to attend our course. Really appreciate. And we pass our hall to the next instruction course. Thank you very much.
I think without wasting much time, we would like to switch over to the next course so that we can maximize the time that we have. Some of you might have been a part of this course. We've been doing it for many years. From the time that the sutureless vitrectomy was evolving, where a lot of people were still converting and a lot of people had not yet moved on to fully a sutureless system, to now an era where most people are even learning sutureless straight away. In fact, a lot of people find it difficult to now suture cannulas because the whole concept of the suturing, the opening the conjunctiva, everything is going away. So over these years, we've been seeing how the whole evolving technology is helping us change totally towards a sutureless modality to a large extent. And sutureless does not mean actually not taking a suture totally. You could probably take a suture at the end, but essentially meaning not opening a conjunctiva and making a larger incision. So, a part of my faculty, Dr. Muralidhar, is here from RIK Bangalore. He's always been a good support for this course and has wonderful experience, and he has also seen this whole evolvement taking place from suture to sutureless. And then Shobhit Tawla, a very dear friend of mine from Lucknow, who's an expert at cataract surgery as well as sutureless. So he brings in the whole combined dynamics of the two surgeries which can be done together. Dr. Somdat Prasad from UK is unable to come at the last minute due to some personal reason, and he was supposed to talk about illumination system. So we, amongst us, would cover that aspect within the premise of our talks. I would first like to invite Dr. Muralidhar to give an introductory talk on what he has seen as an evolvement of this technology, and then we'll go on to other complex areas as well. Dr. Muralidhar.
Thank you, Manish. Good morning. Can I just have a show of hands? How many of you are doing MIVS? You can just lift your hands up. Okay, how many would like to switch over to MIVS? Who are not doing, like to switch over? Okay, we do have a number of people who are not doing MIVS as a routine. In this talk, I'll basically cover how it all started and what it did initially and how we are doing it now and how the scope and the horizon of MIVS is expanded.
Exactly.
Nothing to declare as far as financial disclosures. The initial work was, the credit for introducing sutureless vitrectomy goes to Eugene D. Juan and his team of workers in the MAD lab, and they were the first ones to develop this sutureless vitrectomy on the platform of 25 gauge with the Bosch & Lomb company, and they came out with the first paper just over a decade ago. And this is how the whole thing started. You can see the Bosch & Lomb Millennium 25 gauge vitrectomy as it was introduced. Here the trocar and the cannula system is being used transconjunctivally. I would like you to pay attention to how it is done at that time. See that the trocar and cannula are introduced vertically straight into the sclera without any attempt at displacing the conjunctiva, and then the vitrectomy is done. And this is the exit technique where the trocar is pulled out, and the hypothesis at that time was that 25 gauge opening is small enough, it should be self-sealing, or the vitreous should seal it. Now it's been a decade, and it has evolved quite a bit in a decade's time. The incision technique, what you saw just now, is no more being done, because now we have understood how the sclerotomies should be made, how they heal, how to make a non-leaking or a self-sealing sclerotomy. And I think here the knowledge of the track and the tunnel technique that the phaco surgeons and the SICS surgeons have used have come of great help. Lot more advancements have taken place in the instrumentation. The first generation MIVS vitrectomy probes were very, very difficult to use because they were very flexible, and it was difficult to move the eye. And we have better light sources now, and more importantly, the cutter technology and the fluidics have improved very vastly. So there's been a sea of change in all these areas, and that's how now limits of MIVS, which originally did exist, now have disappeared, and MIVS has really become the standard of care. This is the PATS survey which is done every year by the ASRS, and this is the latest survey done last year, the results of which clearly show where the 20 gauge vitrectomy stands versus the sutureless vitrectomy. This clearly shows that only 3.7% in the US and 7.2% outside US use 20 gauge vitrectomy. The rest all use either 25 or 23 MIVS gauge. So that means over 90% of surgeons today have switched over to MIVS. This is how we started. The original trocar and the cannulas, you can see here, this was a 23 gauge. In fact, we never really took on the 25 gauge system. It was the 23 which we started off with, and the trocar was, as you can see here, trocar and cannula came separately. We had to assemble it, and over a period of years, the better trocar cannula systems have been introduced. This is the Edge Plus trocar cannula, which comes as a preloaded set that we use today. Incision is one of the tips that you need to remember, is go as obliquely as possible. You need to displace the conjunctiva and go in as obliquely as possible. The cotton bud displace the conjunctiva, if you were careful to observe that, and then you go in obliquely till the junction of the trocar and the cannula, and then you rotate it by 90 degrees. And you see how the cannula, once the trocar is removed, how the cannula changes its direction. It's not introduced directly like what was done originally. And here the conjunctiva is displaced, the eye is stabilized, and then the trocar and the cannula is introduced. And now notice here that the trocars available are so sharp that you don't really need to fixate the globe to a great extent. That's one of the advantages of the present day very, very good Edge Plus trocar cannulas. Important thing to remember when you begin is to avoid having a chemosis or a lot of anesthetic coming into the subconjunctival space. Here you see that the anesthetic has come into the subconjunctival space and had made the conjunctiva very boggy. And here you may have difficulty in really putting your cannulas. And what we do here is try and push the anesthetic agent or the conjunctiva. You just mechanically displace the anesthetic, and then you are able to get conjunctiva and sclera together, as you can see here, and then we are able to place the incision. So in the first place, if you are giving the block, make sure you don't get a boggy conjunctiva, because that's going to cause problems to you in your placement of cannulas. Now, even when we are opening the conch, let's say this was a patient who had a dislocated IOL, so I had to explant the IOL and put a scleral fixated IOL. So therefore, we have opened the conjunctiva for our scleral flaps and etc. So even when we open the conjunctiva, we generally no longer go and use 20 gauge with the pre-placed sutures, and we are now using only the 23 gauge, and that's what this video shows, wherein we are using a 23 gauge platform in open conjunctiva. The incision technique is very similar, and you can see that an oblique incision is placed. Now remember that it is not the conjunctiva that's really going to give you a self-sealing wound. Conjunctiva does help to keep the sclerotomy away from the atmosphere, but it is the construction of your wound, the track that you make, the oblique track that you make, that and the intraocular pressure, all those combined would give you the self-sealing sclerotomy. I think Manish is going to show you excellent work that they have done with the OCT on that. Or is it a UBM that you have done? Yes. Now, when we want to remove, the technique I use a light pipe, which is a solid instrument, into the sclerotomy site, and then as we pull out the light pipe, a firm pressure is applied on the sclerotomy site, either with a cotton bud, or another instrument I use often is the depressor with a rounded end, and that's again the infusion technique. When the infusion terminal is being pulled out, we don't change over and use the light pipe, we just pull it out as it is. Just to show you another video, the light pipe is already in and the cannula is removed first, and then the light pipe is removed afterwards, and a firm pressure is applied. If you are beginning to do MIVS, it may be a good idea to do a fluid air exchange at the end of your vitrectomy before you exit from the wound, because it's easier to obtain an airtight closure than a watertight closure. And generally, leakage from the infusion site is never a problem, because you have not really done a great deal of vitrectomy around these. Now that comes back to the question of how much of vitrectomy do we need to do. Now just notice this here, that when I remove these instruments from these two cannulas, there is a free flow of fluid. That means you have done adequate excision of the vitreous skirt. Now why I am telling this point is that the initial period when the 23 gauge vitrectomy or 25 gauge vitrectomy started, it was thought that the sclerotomies would be plugged by the vitreous and then it would heal, and then that's how the self-sealing nature of the sclerotomies were thought to be. Now we know that was the reason why so many complications were more in the sutureless vitrectomy, like endophthalmitis and retinal detachment were seen more in the initial series of 25 gauge vitrectomies. But now we know that the end point of vitrectomy in MIVS does not differ from an end point of vitrectomy in 20 gauge. It's the same. You need to do enough excision of the vitreous skirt to avoid any vitreous incarceration into your sclerotomy wounds. Now, initially when we started doing MIVS, we thought it's difficult to inject silicone oil. So I know that for at least 6 months or 1 year, so sometime we used to open the conch and convert one of these gauges into a 20 gauge to introduce or inject silicone oil. But we know that today we have very good viscous fluid injection systems in the machines available today, and that can inject silicone oil even through a 25 gauge cannula. So silicone oil injection now is definitely possible with MIVS. You don't need to switch over or change one of the sclerotomies. And the way I do it is this is a silicone oil injection in an air-filled eye. This is the silicone viscous fluid injector with the silicone being injected at the control of a foot pedal. And I keep the other, the air is being introduced into the eye all the time. The air pump is on. And I inject silicone oil and let the air go out. This way the eye doesn't collapse. Now, if you clamp the air and then inject silicone oil, the eye tends to collapse, and that's what we don't want to do. So once most of the silicone oil is filled, we close the sclerotomy, we just turn off the air pump, and then we remove one by one, making sure that almost all the air bubble is gone out. We can do PFCL silicone oil exchange also through MIVS. The way I am doing here is the silicone oil is being introduced through the infusion cannula attached to the viscous fluid injector, and through a soft-tipped cannula here, I am aspirating or passively allowing the PFCL to egress from the eye. So this is a passive exchange of silicone oil which is being injected actively through the silicone fluid pump through the infusion cannula. Now this is one way to do a PFCL oil exchange. Sometimes we do run into problems. Now usually what happens when the pressurized silicone oil is being injected under great pressure is that the tubings tend to give way. And what do we do then? I'll show you another video how we manage that situation. This is one case where we started doing silicone PFCL exchange like what I described. The silicone oil was injected through this infusion line, and then we realized that the tubing had come off, and then we had to change over. And what we did in that particular patient was we put the chandelier through the infusion line and used a syringe directly through the other sclerotomy, and this is what happened. The silicone oil tubing came off, and what we did then was we changed we tried to put the tubing. It will never stay. Don't even try it because it's never going to stay. So what I did was I put a chandelier through that infusion port, and I used a syringe which is directly connected to the viscous fluid injector, and used the soft tip cannula through the other port, and the chandelier gave us enough illumination to do a direct PFCL silicone oil exchange. These are some of the things that have come to our use. The chandelier, which allows us to see better and do many more things which we were not able to do. I think Manish is also going to show a use of chandelier for various steps, so without needing to repeat the thing. So chandelier comes to the rescue in many situations. Now, removal of silicone oil. Today, most of our silicone oils are removed through the 23 gauge. The infusion cannula is put in very much the same way, and this is the second cannula to remove the oil which is put in, and then we connect the silicone fluid extractor to this, connect it to the machine. But let me tell you, we can even do this manually using a syringe. Now this is an automated extraction system that's being used, and you can see the bubble slowly gets aspirated. The trick here is to watch out for the last bubble which comes out of the eye. Sometimes it tends to get detached from the inside of the cannula and starts floating around, and that can give you a little bit of tricky problems to remove the last bubble. So as long as you take care and direct your cannula towards that last bubble, you are able to get out. And sometimes I do a partial fluid air exchange. Here what I am doing is the air is being injected through the infusion cannula, and I am using passive aspiration of the fluid so that just the top half of the eye is filled with air, and this allows us to prevent leakages from these sclerotomies. One my practice I have found is that repeat surgeries when you do on the eye, the chances of getting leakage are higher, and then you're probably better off doing a fluid air exchange in some of these cases. 2010 American Academy published an assessment of the ophthalmic technology. They assessed the available literature on the MIVS, and they did come to the conclusion that it is as safe as 20 gauge vitrectomy and has more advantages of rapid healing and less discomfort. So here is a stamp of the organization saying that this is a technique that has withstood the test of time. Some of the accessories that I use whenever I need to do some membrane dissection in the peripheral area, in the close to the posterior pole, I use some of these prisms, to be able to see better. Now here you can see that area we are seeing better using a contact lens system. So you could use some of these adjuncts. It's not necessary that you need to throw out your ring system, occasional patient where you need to do a very, very good membrane dissection, you may need to switch over to your contact lens system with the ring and prisms if required. This is how the chandelier is being put for membrane surgery, for laser, for depression, various steps. The chandelier is of great help. Here we are using it for membrane dissection. I'll show more about this in my talk on PDR. This is a situation where we are trying to laser a peripheral break under PFCL, and because of the small pupil, it is very difficult to get to the break. Now what do we do in this situation? I put a chandelier and then I used a depression, self-depression, to be able to laser the peripheral break that we can visualize much better using your own depression. So these are some of the tips that we can use with chandelier. And lastly, the suturing. I don't shy away from suturing these wounds. How do I suture? I make a small flap, open the conjunctiva, expose the sclerotomy, and put a single 6-0 stitch, as you can see. And the tip I have learnt is that make a flap in such a way that it does not need vicryl suturing. So what we have learned from MIVS is that it's the vicryl stitches, especially used for conjunctival closure, that really cause irritation to the eye. So as long as you avoid them, I think you can really have a very, very clean eye or a very white eye within the next 1 or 2 days after surgery. So should I change to MIVS? I think the reason is obvious here. All of you should change over, because if you want the patient to look like this at the end of 1 week and not like this at the end of 3 weeks. Thank you.
Thank you, Murli, for a wonderful talk. Before I go on to my talk, can I have a quick question to you about especially the incision closure? I think incision making is the key to this whole transforming to the next step of sutureless surgery. So while closing, when you said that you sometimes take a suture, like, if you feel there is a port leak or air is coming out or fluid is coming out and you're comfortable, or there's oil inside and you feel you don't want to let it seep out.
Yes.
Do you find at times a difficulty identifying the site? Because when the air starts coming, it forms a chemosis, and then you can't find the site of the actual incision on the sclera, because you already kind of diverted the conjunctiva a little bit away, and I find that difficult at times.
That's a very good question. What we do at that time is at least temporarily pinch the infusion if it's fluid that's leaking or the air, so that the conjunctiva doesn't keep on becoming boggy. And then you press over the region, you identify where the sclerotomy is and make your flap little away from that, and you're able to really, or once you open the conch, then you can open the infusion, either air pump or the fluid. Then the egress of that bubble will give you the site of the sclerotomy. But sometimes you can have problems in that. It might start bleeding because you're not going to cauterize that. So about a few minutes you might spend.
And when you mention
identifying
cauterize,
that.
Our friend Francisco Boscia from Italy had brought out this whole technique of diathermizing it over the port, to have a better wound closure. Have you ever tried that? Or
I haven't tried that. I know that people have described, but I haven't really tried that, yes.
Okay, so thanks, Murli. Go on to my talk and then we can take it further on from there. These are my financial disclosures. And we've already seen the advent of the 20-gauge wounds to going into sutureless, and that's all thanks to this whole concept of the trocar cannula with Dijuan and his team had evolved, and today all the technology is working on this principle. And quickly going over incisions, because I personally feel it's the key to the whole process, and this is something we were doing in the second generation of the trocar cannulas, where we used to, the earlier ones, Murli showed you the metal ones, and then these ones came in. After that, there's again been evolvement in terms of the way the sharpness of the cannulas have been brought in and how we retract the conjunctiva. So the gross concept remains the same, but the instruments have been refining over a period of time. And this is how we close. Like Murli showed you that he puts a light pipe and brings it out. Even Praveen Dugal I've seen does that and ensures that the vitreous stays away from it. I personally like to massage that wound and try to ensure that there's no leak from there for 10 to 15 seconds, and then take it off and assess the wound. And if at all I feel any kind of ooze, then I would like to take a suture at that stage. But this is how your wound normally looks like, a slit, linear slit which is there. And Murli talked about the vitreous not being, that we like to see a free flow of fluid with 20 gauge, which we used to see, and we don't see the same. And we've done some work in the past with endoscopy to look at what happens to the vitreous when you take off the cannulas. But we did see a lot of vitreous being entangled in that area. And over a period of time, recently we've looked at a very good anterior segment OCT high resolution scans done on day 1, day 7 and day 25 to look at how these incisions of the new generation heal. And you can see that, how clearly you can see that this is a little bit fuzzy because it's got some subconjunctival chemosis, and after that the clarity of the conjunctiva allows us to look at the incision better, and by day 25 you already start seeing that it's clearing off. And we last year also published data on the same in the Asia Pacific Journal. And here you can see the previous generation wound as compared to the linear wounds that are there with the trocars today. So you can imagine how the whole technology itself is helping us getting better wounds at the end of surgery with these. And now you would have another addition, a small hump like this. We just tried some prototypes. You can see this is the normal one, and you might have a hump. This is actually to keep the cannulas from coming off in the middle of surgery. These humps will add as a separate additional retainer inside instead of coming out at times when during the middle of the surgery you remove an instrument and at times you realize that the cannula has come out with it. I'm sure all of you have faced it at some point or the other. Otherwise, everything else remains the same with that. And again, Murli's point of seeing that why the vitreous should be clear, but we cannot actually. If you look at it, the cannula comes up to this area and your cutter is only showing up at this juncture. So all this area, we don't have access to taking the cutter. So there's no way we can actually remove vitreous from around the cannula. So we would have to be satisfied with the concept that there would be some element of vitreous which is playing a role in healing our wounds or keeping the wounds watertight, even though we don't theoretically like that concept in that sense. And then of course the valve cannulas changed a lot where the turbulence was concerned. Every time you would remove instruments, there will be a lot of flow, and especially for cases with retinal detachments and giant tears, we used to face a lot of turbulence. So I think with these valve cannulas, all that has reduced a lot. It's given us a better control inside the globe of the eye, where the fluid going in, coming out, everything is much better controlled. And you also have, these valves also have, the cannulas also have the addition that you don't have to separately hold them while removing the cannula. They are self-retaining, so you can just push them in and bring out the trocar from them without having to hold the tissue there. And once you are inside, there is hardly any turbulence, because every time you remove the instruments, whether it's air fluid exchange, whatever the medium, the valves keep the dynamics in control. And then there is the cutter component, where I think the major change took place when the 5000 cuts came in, which allowed us to go very close to any kind of moving mobile retinal tissue, whether it's breaks, whether it's vitreous attached to this tissue. I think to go very close to that, to get the confidence to do that, I think the whole improvement in the cutter dynamics did that for us. So 5000 cuts was what came up at that point. And then there was a port optimization where the ports moved much closer to the shaft, allowing us to move much closer to the tissue of plane. So in a case like this, where you cannot remove these sheets of vitreous, it's not like a classic PVD. You have to just trim it. And how do you trim it without cutting the retina? Because these cutters are so fine, you can go close to them and just leave a small stump, just cut it flush with the retina as much as possible without creating inadvertent breaks. So that is what these instruments allow us to do. And now from 5000 we are jumping to 7500. So grossly the surgery remains the same, but the leap from 2500 to 5000 did a major change, and now 5000 to 7500 allows us even further superior control over going closer to the retina without being afraid of creating breaks, because the port dynamics makes it, the fast cutting rate allows very little tissue to suddenly come inside your port inadvertently. Now this is a case of a giant tear where we are inserting the 23 gauge, and then we've put a chandelier, and you can see the view with the light today that we have, that which in the past was a problem because we didn't have enough light coming in through the metal halides and the halogens, but now with the xenon and the improved chandelier systems, you can get a remarkable view which allows you to be hands-free in terms of holding another light. But of course, you can use it additionally to illuminate peripheral areas. And also it allows you to see an angular reflex of the vitreous attached to the periphery, which otherwise sometimes is difficult. So you can go to the periphery and in a non-turbulent manner be very close to the retina and still be well illuminated with the chandelier. Also, if you have a chandelier, you can use your other hand, which is free. You can go and indent the periphery and cut the vitreous as close to the base as possible. So the control it allows the surgeon is far superior. Otherwise, you have to depend on an assistant to do the same. So at times, if you require this, you could use the chandelier for the same. And then, of course, the perfluorocarbon to be filled up as for any giant retinal tear, and then the laser done to the extreme periphery, and then an exchange. I personally switched to air and go. A lot of people like Murli showed does a direct exchange at the end of surgery. But the view, basic aim is that the view is very good with the wide angle system. The light is good, and with the improved dynamics of cutters, it makes it a lot more easier to do complex cases. We also published some data on the giant retinal tears recently. Murli is going to talk about specifics to the PDR surgery. I just wanted to show you 2 or 3 cases where I wanted to discuss. A lot of people talk about inside-out dissection and outside-in dissection. I'm just going to show you that I use both and I try both, whichever works better for a particular case. It's fine because I've realized that one particular technique does not work for all these cases. So in this case, we've cleared the vitreous, and I first always try to explore if I can get a peripheral edge to these sheets of proliferations, and if I can, then I would like to resort to that. So here you can see that we got a kind of edge to this whole sheet inferiorly, and so in a circumferential manner, gradually with using a vacuum, gently and assessing how the tissue is moving, because sometimes the adhesions are strong and you don't want to make a break there. So gently use low vacuum and assess. If the whole plane of that tissue moves, then you're probably doing a better job, because it'll take away the full expanse of the membranes and not bits and pieces. So here you see that circumferentially we came and we kind of got hold of that whole tissue, and then slowly went on to the central part, and you can see the small attachments which get peeled off. And from all those areas there would be mild bleeds, which of course you aspirate, raise pressure, maybe do a diathermy to control it, and then do a more finite treatment with the laser as required. While in this case, for me the outside in method did not work. I